Opening remarks here. Thank everyone for joining us. Good morning, good afternoon, and good evening from around the world. I know we have people from all over the world joining this call, and really appreciate your participation. Before we begin, I wanted to extend a special thanks to our partner, APOE4.info, for their participation and their tireless work on building a community to share knowledge and empower patients and caregivers that continues to inspire us all. The APOE4 Alzheimer's Alliance was created with a clear and urgent mission to ensure that individuals who carry APOE4 genotype and their families and caregivers who support them have a voice in research, policy, and access to innovative treatments. APOE4 carriers face a unique and often overlooked risk in Alzheimer's disease. Many develop symptoms earlier, experience faster progression, and carry a heavier emotional and financial burden. Our alliance seeks to change that. In the coming year, we will advocate for greater inclusion for APOE4 carriers in clinical research, expand funding for targeted science, more flexibility and patient-centered FDA, and a reimbursement pathway that recognizes the distinct biology and the unmet needs of this community. We'll continue to highlight the stories of patients and caregivers and build partnerships across academia, the biopharmaceutical industry, and government, so that innovation moves faster and hope becomes reality for those at highest genetic risk. Today's discussion with Dr. Juan Fortea is an important step in that journey. His groundbreaking research helps us understand the unique biology of APOE4-related Alzheimer's and moves us closer to precision medicine for this population. Thank you again for being here and for standing with us in the effort to bring visibility, science, and compassion to those most affected by the Alzheimer's disease. Despite decades of research, the APOE4 population remains underrepresented in clinical trials, underserved in treatment development, and too often overlooked in policy discussions. Now I'd like to turn it over to Nancy Meserve from APOE4.info to talk a little bit about her organization.
Thank you very much. I am going to just briefly share the excitement that the APOE4.info forum Facebook page feels about listening and hearing from Dr. Ashford and Dr. Fortea. Julie Gregory, who's the board president, couldn't be here today, so she asked me to step in. I'm a moderator of the forum, and I co-lead the support group, which includes health coach interns who welcome people the first time they post on our forum. And the mission of this organization, which has been around for 15 years as a nonprofit, is to support people living with APOE4, caring for people who are living with mild cognitive impairment, cardiac problems caused by APOE4, Alzheimer's, and those who know that they have a personal risk. I happen to have 2 copies of APOE4 myself. I, like many others, including the founders of this forum, found out through 23andMe. And to this day, we still get people who join who had never heard of this until they opened up a genetic study and went, uh-oh. So our goal is to meet people where they are, support them in what their goals are, help them have a community when sometimes they are unable to even talk with family members about this, and especially to support personalized and informed interventions that people can choose for themselves, and to support the science and to work with media. And that's why we're so excited to listen to Dr. Ashford and Dr. Fortea today. So thank you.
Thank you, Nancy. Really appreciate that. Now, an opportunity to introduce Dr. Wes Ashford, a distinguished clinician, researcher, and valued member of the APOE4 Alliance Medical Advisory Board. Dr. Ashford is a clinical professor of psychiatry and behavioral sciences at Stanford University and a staff psychiatrist at the Palo Alto VA Hospital, where he also serves the Stanford Alzheimer's Center. A graduate of UC Berkeley and UCLA, where he earned both his MD and PhD in neuroscience, Dr. Ashford has dedicated his career in advancing our understanding of Alzheimer's disease, from measuring dementia severity to improving early screening for mild cognitive impairment and exploring the genetic roots of the disease. His research and advocacy have shaped how we detect, treat, and think about cognitive decline, making him a trusted voice for patients, families, and clinicians alike. pleased to welcome me and having Dr. Ashford join, who will now introduce our featured speaker, Dr. Juan Fortea. Thank you, Dr. Ashford.
Yeah, thank you so much. And I'm so honored to be able to be here in first place. And thank you for that introduction. And I'm going to talk no more than 5 minutes. I got my watch here. I'm going to watch it. But I've got at least an hour of stuff I could talk about, but I'm going to try and just make it sort of interesting and clear and fun. I got started in this field in 1978. I was interested in the temporal lobe, but I was not interested in taking care of old people. But I started realizing that Alzheimer's disease affected the temporal lobe, and then I actually published the first double-blind study of a cholinesterase inhibitor to treat Alzheimer's disease, which is the current main treatment for it. There's no evidence that it is not disease-modifying or that it is any less beneficial than the current anti-amyloid antibodies. They've not been tested head-to-head, and that's one of the things is what is really going on with Alzheimer's disease. It just wasn't enough with the cholinesterase inhibitors to really stop Alzheimer's. That was clear. In 1985, I published an article in New England Journal saying the attack of Alzheimer's disease is on neuroplasticity, and I really believe that's what we have to do. And let's see, there's sort of a story I want to get really quickly through here is I said neuroplasticity, and then in 1992, Hardy and Higgins said, oh, it's the amyloid cascade hypothesis, which made no sense to me, nor a lot of other people in the field, and it still doesn't. And so that was Hardy and Higgins in 1992. I had a good friend named Dale Schenk who actually started the amyloid antibody hypothesis and treatment. Unfortunately, he died September 30th, 2016. And I mention that because the first real study claiming that APOE was related to Alzheimer's disease came out the next year, Corder et al., which I have on the slide here. And you can see here that Alan Roses was actually the major figure in that study. And I knew him very well also. And he died the exact same day, September 30th, 2016. Sorry, he's not here to see what's really become of, the things that he did. Gary Small was a fellow of mine, actually, when I ran the geriatric psychiatry clinic and started the first PET scan studies at UCLA in the early 80s. But anyway, this was the first time that APOE was shown. Now, it's based on what I've told you, there's really three branches of Alzheimer's research. There's the Baptists that believe that beta amyloid is everything. There's the Taoists that believe that tau is everything. And there's the apostates, such as myself, that believe that APOE is everything. And so I've sort of believed that. It took me a while to come around to it, but we had some debates on the subject in 2002 and published this one paper in 2004, using some of what I think are the fundamental laws of aging, the Gompertz law, showing that, Alzheimer's disease, the incidence doubles every 5 years. And if you apply that to the E4, that this would be the Down syndrome, the amyloid beta Alzheimer's disease group, genetic factors really high in their progression. The E4s here, most people here, and then the 3 3s down below, and maybe even the 2 3s lower than that. But you have to understand that these things double every 5 years. From 50 to at least 90 years old, you look at what age do people actually get these, and you're going to find that most of the people are getting these things are the E44s and the E34s. That's men and women. Women get a little more than men, mainly because I believe they live longer and they take better care of themselves than us men do. If you look, I think that once you look at these things, you have to understand the basic survival mechanisms, Gompertz laws and survival characteristics, and this is what we suggested was the progression of Alzheimer's. This would be the E4, the E34, and the E33 here, and that would be the black line was the whole population. But what we basically suggested is that at age 75, 90% of the Alzheimer patients before age 75 are APOE carriers. And this has just been totally ignored by the field. It's just incredible. So we argued this, we published papers on this. And then last year, Dr. Fortea published these things that are basically, I want to say, consistent with what we saw. I'm sure he'll show more about these, but it's totally consistent. But the thing is, he said it in a way that was able to totally change this field, which has been desperately needed since Alan Roses proposed this in 1993. It's been 20, 32 years since then. And we need to go on. And that his real contribution is saying what, a lot of us know, but in ways that other people believed it. And so I just really very, very grateful to him for the paper and for his activation in this area. And I really appreciate it. I look forward to him talking. Thank you so much for letting me introduce this field.
Thank you so much, Dr. Ashford. And before I turn it over to Dr. Fortea, I just want to make sure we are clear. This is a situation where we want to be positive in nature. We don't want personal attacks against anybody. We're not opening up the chat today because we wanted to avoid those types of comments. Please feel free to ask questions in the Q&A box. That we will have someone monitor those and try to collate them at the end for Dr. Fortea or Dr. Ashford. And with that, I'll turn it over to Dr. Fortea, and thank you so much again.
Thank you very much. I'm very, very glad to be here. To Dr. Ashford for this. It's a fantastic introduction to what I want to talk about today. So let's put up my slides. I think you're seeing them, right? Okay. So what I'm gonna talk is about this concept of genetically determined AD, which, by the way, is a concept that we coined to introduce Down syndrome as within the family of genetically determined AD. And in the paper that I'm gonna mainly talk about today is this concept that maybe APOE4 homozygotes should be also included in this family. So these are my disclosures. So I consult for a number of companies developing drugs in this space, in sporadic AD, Down syndrome associated Alzheimer's disease, and also APOE. So let me start with what I'm going to talk about, the outline. And so let's first start with the outline and the consequences. And I think this sentence clearly explains why this paper was so controversial. Because as Dr. Ashford has mentioned, this APOE has been recognized as the main genetic factor behind Alzheimer's disease for many decades. But basically, if you look at it this way, we would be saying that if including APOE4 homozygotes in genetically determined AD increases the prevalence of these genetic forms to more than 50% of symptomatic AD, from far less than 1% if we only consider autosomal dominant AD. And that means that more than 15% of the cases, the cause will be clearly identified in just one genetic factor. And this, of course, has generated a lot of controversy. So what I'm going to structure my talk is first showing the evidence supporting that APOE4 homozygotes indeed should be considered as a distinct form. So basically, I'll review the paper. Then I will signal some areas of controversy around it and some work that, in my mind, needs to be done, and acknowledge that there is a controversy here. And certainly, I would like to end up with a call for action and reasons for being optimistic, because I truly think there are many reasons to be optimistic and to prioritize APOE homozygotes in prevention, therapeutic trials, and more research in APOE. So let's start with the genetic architecture. This is the kind of slides that you would see in all the conference for Alzheimer's disease, and tries to summarize the genetic architecture of the disease. And here what you're seeing is two axes. So in the x-axis, you are seeing the frequency of the different genes or mutations, if you will. And so the more to the right that you're here, the more frequent this genetic factor is in the population. And in the y-axis, we depict the risk that these genetic forms, these mutations or these variants confer for Alzheimer's disease. And here I would like to say that details matters, and these axes are broken. And are broken here in the x-axis, saying that this is more or less frequent, and this is rare, very, very rare. And the same here in the y-axis, denoting something that is causal and something that is only a risk factor. And so here we end up having this small, very small proportion of cases. This is autosomal dominant AD due to mutations in the presenilin 1, 2, and APP genes that have received a lot of attention, a lot of investment, because they are considered to be causal of Alzheimer's disease. Whereas the rest are considered risk factors, very, very important to understand the pathophysiology, identify targets, but we've been less effective in really targeting those at least in clinical research, and I'd say also clinical trials. And whenever I present this slide, I always say there is an elephant in the room, and that's a Down syndrome-associated Alzheimer's disease, which I think now we've come over the controversy. I would like to emphasize this and I have a few slides here, but sometimes people don't talk about Down syndrome, and certainly it's a model of genetically determined disease, Alzheimer's disease, and the reason why we coined that. And of course, we're here today to talk about APOE homozygotes. So, and I don't want to play with words, but I think that you also would be aware that in order to define what is genetically determined Alzheimer's disease, first, we should agree on what is Alzheimer's disease. And here things are not as clear. And I think that in order to put some order into the controversies and to put some rationale here, I think that rules matter. So I think that in science and in sports, rules matter. Why do I say that? Because in Alzheimer's, we still haven't reached unanimous agreement on how to define Alzheimer's disease. This is a slide in which we can see the evolution of all the criteria on how to define Alzheimer's disease. And I would say that today we have two sets of criteria. We have the Alzheimer's Association criteria that were published in 2024 that define the disease as biologically, and the international working group that classifies the disease from a clinical biological perspective. So let me dive a bit more into this concept. This is a crucial difference. Because basically the Alzheimer's Association criteria, which by the way, I must admit that I favor, I'm not saying that the International Working Group don't make valid points, but I think that the Alzheimer's Association criteria define the disease biologically. So basically, they argue that if you have the biology of Alzheimer's disease, and this can be demonstrated in life through biomarkers, basically you do have Alzheimer's disease. Whereas the International Working Group says, no, wait a minute, you need a clinical syndrome in order to define the disease. This is the clinical biological definition. And why is it important? Because it has tremendous implications on the penetrance, on how many people we're talking about. So here is data from the US, and you can see in millions how many people you have with AD dementia or MCI. So the dotted lines, the pink one and the red one, that would be symptomatic Alzheimer's disease. Whereas all these huge curves is if we include people with biomarkers of Alzheimer's disease. So you'll see that we'll discuss several times the penetrance of disease, how much it manifests. It completely changes. If we're talking about the biological definition of the disease, or if we are talking about the clinical biological definition of the disease. So the first thing when we analyze the data is, are we talking about biology, or are we talking about symptoms? And I have to start saying that our paper took and followed the Alzheimer's Association definition, the biological definition of the disease, that does not take into consideration clinical symptoms. However, and more advanced in the talk, I will also give a few words about the clinical symptomatology and the clinical penetrance of the disease. But please bear in mind that when we're discussing one thing, we should state that things, so you cannot support Alzheimer's Association criteria and criticize the reconceptualization of APOE homozygotes based on clinical symptomatology. We think we need internal consistency and being consistent. As you say, we need rules on how to discuss these very important issues that have huge implications, and we all are aware of that. So I'll start by moving into the evidence supporting the APOE4 as a distinct form of Alzheimer's disease and the origin of the proposal. So I would be talking about the Nature Medicine paper and where it came from. And I have to start by saying that this conceptualization comes from a similar reconceptualization that we and others have been doing in the last decades for Down syndrome. There was huge controversy also in the field of Down syndrome, and I think that you will see that now it is widely recognized that that DSAD is a form of Alzheimer's disease. And if you read this paper that we published in 2021, the title is very, very similar. So basically what we are doing in APOE4 homozygotes, what we are proposing is something we propose in people with Down syndrome. And I have to say that, first of all, I am extremely sensitive to the impact that these reconceptualizations have. We've been there with Down syndrome, which is a very vulnerable population, and we are very, very much aware of the impact that these kind of proposals have. But I also have to say that this is the first and necessary step to really increase funding, attention, and research to fight against Alzheimer's. I think that we should follow the data and really move forward to really fight against the disease. So a bit about Down syndrome, and you'll see that what we've been publishing in Down syndrome is something that we did afterwards in APOE4 homozygotes. Down syndrome, you all know, is a trisomy of chromosome 21. So instead of having 2 chromosomes of 21, they have 3. And within the chromosome 21, it's located the amyloid precursor protein, this gene. And so if any of you would have 3 copies of this gene, you would develop Alzheimer's disease, no doubt, of presonal onset. So it becomes, in essence, this as a form of autosomal dominant AD, if you will. Of course, the inheritance is different, but the idea is the biology behind it is the overproduction, a gene dose effect on the amyloid precursor protein. There was huge debate, and I think this is an area that needs a lot more research also in APOE4 homozygotes, but now long prospective observational clinical studies such as this one made in Ireland that followed individuals for 17 years in this paper clearly established that here the clinical penetrance, I'm talking this as an exception, is a clinical penetrance of the disease in Down syndrome is over 90-95%. And as late as last year, it was the first time that the Alzheimer's Association included that people with Down syndrome in the genetic forms of Alzheimer's disease at the same level as autosomal dominant AD. This is a huge step forward and something that came, as you know, as you are seeing, very, very late. Until last year, the Alzheimer's Association criteria did not include Down syndrome in their criteria, because of the gaps they felt that we have been able to surmount with the research in the last few years. So, and this that comes from the editorial in the Lancet Neurology. What we argue is that there are 3 core characteristics for genetically determined AD. So first, you should have, and this should lead to near full penetrance, and I'll say that this is arguable too, but near full penetrance of the disease, that it should have a predictable symptom onset and a predictable sequence of AD biomarker changes. These are things that all these genetic forms usually have in common. And so first I'm gonna show AD is always the model and what happens in Down syndrome, and of course then I'll move on to homozygotes. So, what was the kind of evidence that we developed for to support Down syndrome, to the reconceptualization of Down syndrome? First, as I said, things that we know that biologically the penetrance is full. By 40 years, we know in pathological studies they all have AD biology. In biomarker studies, as you will see, in the last 10 years, we've done tremendous advances in showing the penetrance of the biological penetrance, and in this case of Down syndrome, also the clinical penetrance is very, very large, almost near full penetrance. And this is another way to looking at it. Is like if you follow individuals, so you just imagine here, where luckily in the APOE4 homozygotes are not at this, do not show this kind of risk clinically. Here you see, for instance, this is following people with Down syndrome that have no symptom whatsoever at the beginning of the study. I follow them for only 5 years. The red dots are those that are over 50 years of age. So if you follow 100 individuals, 100 individuals or 1,000 individuals with Down syndrome over the age of 50 with no symptoms at the beginning, more than 50% will develop Alzheimer's, symptomatic Alzheimer's disease in 5 years. That's the risk they're facing. So that's why I'm saying that I'm very, very sensitive to the implications but I think we need to confront it. We really need to fight against this. So what about predictability? Here we did a meta-analysis in which we analyzed the age at AD dementia diagnosis across all the studies that we could find in the last 30 years, mainly in Europe and the US. And as you can see, first thing is that even though we didn't have a harmonization on how to diagnose the disease, so everyone did as good as they could, you could see that all the studies, they really found like a very consistent age of symptom onset. And basically, an individual with Down syndrome develops Alzheimer's at age 54, approximately. But as I came from the field of autosomal dominant AD, I thought that there was a dogma in the field of Down syndrome that didn't hold. And so we had this idea that Down syndrome was extremely variable with respect to the symptom onset. And that's because we've seen a lot of individuals with Down syndrome, age 45, 43, 48, that had AD dementia. And we also, all that work with people with Down syndrome, we've seen individuals age 58 that did not have Alzheimer's. So the idea, the clinical impression that you have as a clinician is that this is very variable. But as I said, I came from the field of the autosomal dominant AD. I did my PhD here, and I worked with them for several years in biomarker research. The numbers look very similar. And here, what I want to say is that in red, we have many studies with Down syndrome. In blue, we have many studies in autosomal dominant AD. And here, the dots, as you can see, are basically the same. And this is saying how the coefficients of variation, the span of symptom onset, the prediction intervals, essentially we're seeing how much the presentation changes with respect to age. And as you can see, in red is people with Down syndrome. And this bar is no greater than the others. And this has huge implications because it means that the way we should analyze the data in Down syndrome should be very similar to autosomal dominant AD. The statistical modeling, how we should analyze the data is completely different. And you'll see that all this I'm explaining will apply directly to APOE4 homozygotes. This is the paper, the first paper that we published in 2020, in which we could show the natural history of the AD biomarker changes. And here what you see is euploid control, so the general population, no Down syndrome in blue, and people with Down syndrome in red. And you can see in the x-axis is decades. It's very small, but this is 20 years, 30 years, 40 years, 50 years. And you can see that decades before symptom onset, the dotted lines, decades before, we can see dramatic changes in several AD biomarkers. And we can establish a sequence of events. And if we do that and we color code the biomarkers in the main categories, so those in blue, those in amyloid, in green, those referring to tau, and in yellow, those of neurodegeneration, the point I want to make is that the models, and we analyze the chronopathology, how the disease unfolds across the lifespan, you can see that the chronopathology, this unfolding of the disease, is extremely similar in Down syndrome and autosomal dominant AD. So now you'll see that the Nature Medicine paper is essentially recapitulating these several studies and dozens of studies that we've been publishing in Down syndrome and applying those studies, this view, this prism to APOE4 homozygotes. So the first thing I need to say is that in order to do that, you need huge numbers. And this has been one of the main reasons why it took us so long to do this paper. The idea that APOE4 is very important for Alzheimer's, and a lot of the data was out there. And as Dr. Ashford mentioned, many of the individual ideas were already there. But what we were lacking, and we managed to do, is to gather very, very, very large numbers that weren't just there, easy to gather 10 years ago, for instance. So just to give you an idea, in the pathological study, in the NAC database, we collected over 3,000 individuals, and we analyzed the AD pathology. The AD pathology by haplotype. This database is composed largely or to a great extent of people with dementia and MCI. This is important. There is a bias towards people that have died with symptomatic Alzheimer's disease. So we see more pathology than we would see in the general population. But even though, if we analyze the people that died there and are analyzed in the NAC database, you can see that in red is the high, very important AD pathology, intermediate, that is also considered very consistent with AD pathology, and in this kind of bluish or purple colors, no or very low pathology. You can see that there is a huge difference between APOE4 homozygotes and APOE3 homozygotes. There is a lot more AD biology and happening earlier than in APOE homozygotes. And the other thing that we needed to do is to gather an even larger number of individuals clinically in the clinical cohorts. We needed to gather 5 of the largest cohorts in the world to really be able to collect over 10,000 individuals. Just imagine the effort this was for all the PI, the family, and the clinicians around the world. And here what we did is analyze not the pathology, but the biomarkers. So in the left lower panel is the amyloid markers, in the right lower panel, the tau markers. And you can see again in the APOE homozygotes in red, and in green, the APOE3 homozygotes. So you can see that as a homozygote age, almost all of them accumulate amyloid and accumulate tau, such as that by age 80, they basically all of them have amyloid and tau. And this is why we said in the paper that there is a near full penetrance of AD biology in these datasets. We'll discuss about this, the representativeness of these datasets. But there is a near full penetrance of AD biology in APOE homozygotes, as demonstrated by the pathological part of the study and the biomarker part of the study. This has already been shown. This is basically a replication of previous replication or demonstration again of the replication, yes, of previous works that basically, as Dr. Ashford said, APOE4 homozygotes have not only a much higher risk of developing the biology and the symptoms, but also at earlier ages. So it doesn't matter if you look at symptom onset, MCI onset, AD dementia onset, or death due to Alzheimer's disease, the homozygotes tend to be much younger than APOE3 carriers. But if we do 2 homozygotes, and this is completely new data, to my knowledge, this hadn't been assessed before, and we say, okay, all the people that in the NAC database that develop AD symptomatology, AD dementia or AD MCI, and we analyze how variable is this disease onset, and we create a 95 prediction interval the same way that we did it for Down syndrome, you can see that APOE4 homozygotes have clearly smaller bars than APOE3 homozygotes and very similar to this genetic form. So let me plot it in a different way. So we are again plotting the prediction intervals, and you can see that DSAD, presenting one, and APOE4 homozygotes have very similar prediction interval. So the variability around symptom onset, which in APOE4 homozygotes is age 65, a similar for symptom onset, not MCI and dementia that we'll have it later. The similar variability as in the genetic form of Alzheimer's disease, and a clear gene dose increase in these prediction intervals when you have you're heterozygote or homozygote, APOE4 homozygote. So again, similar predictability of disease onset with respect to AD or DS-AD. And what about if we look to the biomarker changes? And let me emphasize, and this is the merit of the PIs that were so generous to share the data. Every dot here is a participant, is an individual that really contributed with his or her time, effort to these studies. And just imagine how many lumbar punctures, for instance, or how many PET scans. There is a huge effort behind this slide. And here what we're doing is basically the same, is putting the age in the x-axis and the biomarker levels in the y-axis. So we're seeing here 4 decades, basically. And you can see that APOE homozygotes, heterozygotes, and non-carriers have completely different trajectories with respect to the timing of the biomarker changes. Very, very different, in a very clear gene dose response. And if we do the modeling to assess the chronopathology, or again, how the disease unfolds in APOE homozygotes, and we color code that, you can see that the trajectory of the biomarker changes, the temporality of when these biomarkers change with respect to the predictor's age of symptom onset, and this again was something new, is very, very similar between homozygotes, DS-AD, and autosomal dominant AD. So striking similar temporalities for the biomarker changes in all forms of genetically determined Alzheimer's disease. So if, and this is a summary slide for this part of the presentation, if we apply the Alzheimer's Association criteria that defines the disease biologically, then yes, we can say that yes, APOE4 homozygotes have near full penetrance of AD, at least in these selected samples. That yes, there is a predictability of AD symptom onset to the same level as the other forms of Alzheimer's disease. And yes, there is a predictable sequence of AD biomarker changes in this population that is very similar to that described in Down syndrome and autosomal dominant AD. So yes, I think that these 3 core characteristics of genetically determined AD are met if we apply the Alzheimer's Association criteria for the disease. So where are the areas of controversy? That is a valid controversy. There are several points that are very, very valid. So let me identify some areas of controversy. And here, let me, if you're interested in a very clever editorial with very, very valid points, I would recommend you reading this editorial in JAMA Neurology by Eric Reimann, who is an amazing scientist that has worked with also autosomal dominant AD in Colombia, with APOE4 for many decades. He's made tremendous contributions. And this viewpoint, he was a bit, raised several valid points criticizing, I wouldn't say, or signaling areas of controversy with respect to this proposal. And let me also cite a reply after we published the Nature Medicine paper. There was an editorial or a comment to our paper, and we had a chance to reply. So some of this controversy we've contributed in written, so to speak, and some of the responses to several of these points we published a few weeks or months after the publication of the paper. So first of all is the clinical penetrance, as I said, because it is clear that lifetime risk estimates vary and that not all APOE4 homozygotes will develop MCI or AD dementia. This is very clear. Also, another very important point is the racial differences and the selection bias that we might have, and the lack of population diversity in the study, which is very, very clear. This is a problem that we have in AD research in general. So basically, most of the research so far has been done in the US and Europe with people of Caucasian descent, of European descent, and we really need diversity, and you'll see that this can be very, very important, specifically in this area of research, and so we really need population-based longitudinal studies, especially those including diverse racial, ethnic, and geographic groups, because things can be different. And I'll show you some of the results. And then there was some controversy about the modifiers. The idea is that in genetic determined AD, it's true that when you have such a strong driver, the modifiers have less power to modify the disease to a certain extent, or at least this is something that some people have raised significantly when analyzing our proposal of reconceptualization of APOE4. So let's dive into some of these issues. So first of all, does a mutation need to be fully penetrant clinically? And I'd argue no. I think this is something that in Alzheimer's we've come to believe because our model for genetically determined AD has been autosomal dominant AD, this presenilin 1, presenilin 2, and APP mutations that do have full penetrance, clinical penetrance. But let me just look outside of neurology for instance. And if you take, this is a very well-known mutation, no? The BRCA1 and BRCA2 mutation. And this is the risk that they confer for breast cancer, for ovarian cancer, and no one discusses that this is a genetic cause of cancer. Actually, many women take out their breasts if they have these mutations in order to avoid developing cancer. And I have to say that we did not, because we could not assess the clinical penetrance of the disease in our study because of the selection bias that we have in the people that were more towards the symptomatic stage of disease, and the clinical cohorts, the opposite, they were more cognitively healthy. So we could not assess that. In a paper, you cannot find the clinical penetrance, we could not assess it. But of course, because there is a lot of research in this field, in literature, you can see that it's established, and this is, for instance, a Nature Medicine paper of this year, that the lifetime risk of AD dementia is probably in the 40 to 60%. In this study, it was 60%. The lifetime risk of developing dementia if you are APOE4 homozygote. Let me introduce you the nuance that if you add MCI, that all agree is symptomatic Alzheimer's disease, these numbers will be even higher. Of course, if you add symptomatic AD and then you move away from the International Working Group to Alzheimer's disease, the number would be even higher. But even with the symptomatic stages, again, rules, the lifetime risk of APOE4 homozygotes is at the same level as many diseases outside neurology. And what happens in neurology? In neurology, there are diseases that no one doubts are of genetic origin. For instance, the C9 expansion. And here there is a controversy of what's the clinical penetrance of this mutation. But the estimates in some papers, recent papers you can see here, are less than 40%. Why is it a mutation that confers less than 40% risk for the clinical syndrome? Genetic in other areas, and something that confers a 40 to 60% risk is not genetic because it's not fully penetrant. That's a thing that, again, we really need rules and be consistent, even across neurology and across medicine, on how we define the risk conferred by a mutation. The racial thing is even more important, and because there is very good epidemiological evidence that the risk conferred by the APOE gene, haplotype, zygotes and heterozygotes, here, homozygotes to the right, heterozygotes to the right. And here you can see East Asian, non-white, non-Hispanic white, non-Hispanic black, and Hispanic. And you can see that the odds ratio conferred by the haplotype clearly is different across the different ethnic groups, such as that East Asians are considered to have the highest risk if they are carriers of the APOE4, and Hispanic and non-Hispanic black are considered the risk conferred by the APOE haplotype is considered to be smaller. I have to say, however, that all these studies have been done by clinical genetic studies. So here, most of what we know in this kind of studies is done by a clinical diagnosis of the disease, oftentimes or most often not supported with biomarkers. And that can be one of the reasons why we are seeing such important racial difference. But in any case, this is hugely important because until we really solve these issues, it's very difficult to really inform and do the genetic counseling to a homozygote, because it's very difficult to know what is the specific risk for that person, because there is no doubt, and I would agree with the people that are concerned about the implication, that what a person is really concerned of is not whether he or she will develop amyloidosis when they are 80. What they are concerned is whether or not they will lose memory of whatnot, even more cognitive complaints. So we really need to estimate these risks and really understand the effects of the ethnic background. So in order to do that, we team up with Claudia Suemoto in Sao Paulo. And the reason to do that is because in the NAC database, the one we analyzed, basically there is not enough ethnic diversity. You go there, almost all the brains that are available in the NAC database are white. So here in Sao Paulo, they have, which is a huge city in Brazil, as you all know, they have many deaths, as in a big city, but they have a very interesting autopsy service that in those people that do not have a clear diagnosis of non-traumatic deaths without medical assistance or undetermined causes during life, they'll do a lot of autopsy. So it's a very clear source of having many brains analyzed with there. Of course, they're healthier and probably they have less dementia than what it's a different bias. It's very difficult to escape bias when you're doing pathological studies, but it is population-based, and it has a lot more diversity. And they are collecting many brains and doing an amazing work there in Brazil. So they've collected over 2,600 participants. So our paper with the whole of the US, it was based on in the end up we ended up with 3,000. So just imagine how huge effort they are doing there. They have much more diversity there, and this is, as I said, it's a bias towards much more asymptomatic individuals. So it's very different, a very different picture from the NAC database, in the sense that it's much more ethnic diversity and many people that died with no symptoms whatsoever of the disease, whereas in the NAC database it was symptomatic individuals. So that's very important to consider the disease. So here what we analyzed is that here the biological penetrance of the disease, so the BRCA stages, yes, you can see the different haplotypes, so 4/4s, 3/4s, 3/3s, 2 something. So if you look at the left column, you can see that, of course, the more gene dose you have, the more red, yellow that you have. There's no doubt that also in this data set, also in this cognitively unimpaired, diverse population, the impact of APOE4 is huge. It might not be fully penetrant, could be. Do bear in mind that this is biased to more cognitively impaired, but there is maybe the penetrance is lesser than in the bias samples that we had in the Nature Medicine paper. That's an important result. But another very interesting result is that here, when you analyze the biology, when you analyze the pathology in this case of the disease, we did not see that Black participants had less AD than the white participants. So this clinical genetic association that clearly have been established in the literature, we could not see in this study. So let me end up for a call for action to prioritize APOE homozygotes in prevention and therapeutic trials. I think that this is extremely important, and there are reasons to be very optimistic. because I do believe we can defeat AD in APOE4 homozygotes and the genetic population. I do believe we can do it, and we really need to tackle this problem. So this is something that is reasons for optimism. I think that now, if you're an APOE4 homozygotes, you should read this slide. And clearly there are reasons for, I mean, of course we need the data. We need a positive trials to prevent the disease. But the same drugs that we are now administering in the symptomatic participants, I'm talking about Leqembi and Kinsula, the donanemab and lecanemab. Now they are being tried in the HEAD study, lecanemab, and Lilly is also having secondary prevention trials. The HEAD study is fully enrolled. It's going to read out in 2 years, and it's going to tell us if removing amyloid in the presymptomatic stages of the disease delays the onset of symptoms. And if this happens, it will be completely different scenario. We'll have the answer in just 2 years. And it's just the spearhead of many other trials that are coming in the future. But we do have some indirect evidence. This was a paper that was published earlier this year in the Lancet Neurology by the group of Randy Bateman in WashU in the Diane study. And there they took a trial that had been negative, gantenerumab. You know that gantenerumab is a trial that did not remove amyloid as efficiently as lecanemab or donanemab, but removed amyloid to a certain extent. And so basically here they followed individuals for many, many years. And there they have, with small numbers at the end of the study, but those that had received gantenerumab for longer, they had 50%, more than 50% reduction of progression to symptomatic AD. Again, this is a failed trial and very long and very small numbers at the end of the study, but evidence to suggest, in agreement with the rationale, that maybe administering and removing amyloid, at least in these genetic populations, can delay the onset of Alzheimer's disease, the symptomatic Alzheimer's disease, significantly. So, of course, there are more trials in autosomal dominant AD, trying newer generation of these drugs. Hopefully, we'll start doing the same, and we're already doing the same in Down syndrome with active vaccination, and hopefully soon with antibodies too. So I think there is reasons to believe that maybe in a few years we might have drugs that are effective in delaying or preventing Alzheimer's. So reasons for optimism. So in order to do that, we need to have trials in APOE, focused on APOE homozygotes. And that's not only because if you move preclinical and certainly to primary prevention, for instance, the numbers are much smaller because homozygotes represent around 15% of symptomatic AD patients, but only 2% of the general population. So we really need to enrich for homozygotes. And that's because there are biological differences. So for instance, the response to and this is a problem, I'll show you some things that are more optimistic, but the side effects of the drugs that we have for Alzheimer's disease have a huge gene dose response to. So if you are a homozygote, you do have more risk of developing side effects if you are receiving these drugs. As you can see here, for instance, here is area H, but with area E, edema, and these hemorrhages, the risk for developing some side effects is much higher if you are homozygote. So clearly, if you have a differential response, be it risk, be it efficacy, we really need to analyze the data separately. Luckily, there have been some people already in the field that have recognized that for much earlier than we did. And so, for instance, Alceon, they ran the APOLLO-E4, and this is really interesting for many things. Basically, because in this and the next example, they are doing repurposing of drugs. So here, the tramiprosate is a trial that was negative, not a failed trial, a trial that was negative a few years ago in Alzheimer's, but they clearly had the patience and the intelligence to look into the data and think that maybe APOE4 homozygotes would benefit for tramiprosate. which is a molecule that inhibits the oligomerization of A beta oligomers. And although they recently published the main results and didn't find that significant overall cognitive benefit, in a pre-specified analysis, they saw that maybe patients in the MCA stage of AD, they might benefit here. And they had a very favorable safety profile, and it was an oral compound. And they also showed some very encouraging data in the rate of brain atrophy. So again, this is repurposing and recognizing that APOE4 homozygotes might have a different perspective. A different trial that is now ongoing, and is probably Dr. Ashford can tell us much more about it, is we met that night, which is something that we are doing for hypertension, basically in medicine. But Dr. Wang clearly identified that very specific transcriptomic reversal of APOE specific signature. That means that he recognized that APOE4 was having a very specific signature, and analyzed what compounds that we already were using in medicine could reverse some of these studies. They went on to animal models, and they showed that that drug could prevent some of the hallmarks of the disease in the animal models. They went to databases of people that had been using this drug in the general population and showed that maybe that these people showed less AD-DMS. And then they move on to a clinical trial run at Stanford to really see if this worked. So again, it was the intelligence of focusing and analyzing the distinctiveness of APOE homozygotes and trying to in this case, take advantage of the knowledge that we gain to really fight Alzheimer's in this subpopulation of the disease. And this is another very recent example of published this year also in Nature Medicine in July. And here what they did is analyze another huge database, mainly composed of women, but then a replication cohort of men, that follow individuals for many years, 1989, sorry, and this is 30 years more than 30 years of follow-up. So in Alzheimer's, we need long follow-ups, and we really need large numbers. This is 6,000 individuals. What did this show us? Again, in this study, if you are a homozygote, the risk in this study for these many months, you can see is over 40%. And this is a longitudinal prospective study. And probably if we increase the follow-up, probably the numbers increase. So again, confirming this ultra high risk or very high risk of symptoms onset. Again, this is for dementia. If we include MCI, it would be higher. But the very interesting thing is that they found that the metabolic profile on APOE4 homozygote was different from that of heterozygotes and non-carriers. And what's really nice is that the Mediterranean diet seemed to be much more effective on homozygotes than non-carriers or heterozygotes. So the people that benefited most from a healthy diet were those that were homozygotes. So again, we really need, if we want to do precision medicine, probably the best place to start is by analyzing the APOE genotype. Because I think that together we can defeat Alzheimer's and Down syndrome. And here is time for action. Really, what you are doing, just gathering together, lobbying, and contributing to studies, this is the way forward to fight the disease. We really need to clarify the APOE biology. We really need to define more cells type-specific mechanisms. We really need, I do believe, construct APOE4 enriched cohorts. We really need to understand better the biological versus clinical risk across disease stages in diverse populations, so we truly can inform and do the genetic counseling to the person with really good data. And we need to identify the best therapeutic timing for the different drugs at the different timing of the disease. And certainly we need targeted APOE-directed therapies, because we did not consider it causal, because we did not consider it a genetic form. Most of our attention has gone to the mechanism identified in autosomal dominant AD, in presenting 1, 2, and APP mutations. We certainly need to do the same kind of investment, if not more, in APOE-related therapies. And this is, for instance, something that we hope we'll be able to do in Barcelona in the next few years. We're trying to collect and raise funding for the BRAVE-AD trial. It has been mentioned, APOE4 is not just a question only of the brain. Of course, it's a systemic. It also has vascular components. It might affect the eye. And so this is a cohort that we want to launch, really enrich for APOE4 homozygotes. So basically, we recruit several hundreds of people with homozygotes. We'll also include some people with APOE2, that I think is another very interesting population. And we're going to try to do multimodal assessments, build a cohort there and try to nest clinical trials and accelerate the disease in the coming years. And with that, I hope I've convinced you to provide evidence of why not only do we have an elephant in the room with Alzheimer's, and with all my respect, we do have a mammoth in the room, which is APOE4 homozygote. As I said, this would mean that 15 to 20% of the symptomatic AD would be genetically determined. And this is my true belief. All my research in the last 20 years has revolved about these genetic forms of Alzheimer's disease. As I started with AD, and then I moved to Down syndrome associated Alzheimer's disease, and now we're putting all of our efforts trying to fight Alzheimer's in APOE homozygotes. And with that, I'll finish and saying that APOE4 homozygotes, in our view, should be included in the growing family of genetically determined AD with near full biological penetrance. Because of the predictability of this biological penetrance, the predictability of disease onset, the sequence of biomarker changes. And because of this predictability, these populations are ideal to perform secondary prevention trials. And really, we need to analyze the differential response to treatments, both in terms of efficacy and in terms of safety. And all the trials should be powered to really analyze if they are equally effective and safe in APOE homozygotes. And as I said, that this is my true belief that AD, because we know the cause, might be easier to cure in this population than in the general population, in which probably a myriad of environmental factors are playing a larger role and might be more difficult to identify subpopulation. Here we have more homogeneity, and this should help us fight the disease. And with that, I'll end up by thanking all the participants. I always put people with Down syndrome. They are a vulnerable population that really teaching us a lot. And I think that the work that we did in APOE homozygotes in-depths a lot to the research we did in them, but of course to all the APOE homozygotes that have participated in our studies, all our colleagues, and the memory unit in Barcelona. And with that, I'll be very happy to take questions. Thank you very much.
Well, Dr. Fortea, thank you so much for your presentation. Obviously, what you presented today is sobering to some, right? Love to have you expound. You talked a lot about potential hope and opportunities in clinical trials. Maybe you can expound upon that so people can, recognize the hope that's right in front of us, really.
No, I think that in my view, and as you've seen, and from the beginning, as Dr. asked for a presentation, there are some critical debates, and a debate is good if we really channel it significantly. But for instance, I think that just APOE4 homozygotes, in my mind, they should play and go always they can with the general population in also that they're included in all the trials, they take advantage. They don't suffer from what the Down syndrome community has suffered, that they are not included in trials, that they are not. So APOE homozygotes, they should be in the mainstream, but they should be recognized also as distinct. And we really, sometimes they will need targeted trials with specific mechanisms that are targeted to them. And certainly we need to analyze always the efficacy and the safety in this subpopulation. And my first reason for hope is these secondary prevention trials. A lot of the risk, I'm not saying all, but a lot of the risk conferred by the APOE genotype also at some point of the disease stage is conferred also by amyloid. So people with APOE, and this we know for many years, that APOE homozygotes, they accumulate much more amyloid and sooner. Of course, the group in which you and others have shown that there are other mechanisms. I'm not just simplifying that, but amyloid is one thing. With that, I mean that it is reasonable to hope that if the secondary prevention trials are positive, if the AHEAD study and the Lilly trials and the Roche trials are to come with new generation drugs, they really prevent the disease in the general population. Probably they will also prevent or delay the disease in the general population. So that's something that in just 2 years, we can be in a completely new scenario in preventing the disease. So that's one thing. And the other is this recognition. As if we really recognize that we should focus here, I think that what this repurposing of drugs, this creating cohorts, these specific targeting therapies that we have. I think we were in an amazing times in Alzheimer's. Really, for those of us that have been for a number of years already, we were like failure after failure. And we are growing hope because of the much deeper understanding of the biology, the better biomarkers, and the better trials that we have. We're in the moment that now times have accelerated so much that we have amazing, larger cohorts, better consortia, more bigger funding, much better biomarkers, new delivery systems. For instance, the way that we can deliver now drugs to the brain is much more effective. I honestly believe that there is a lot of reason for optimism, but a lot of work ahead of us. And certainly, as I said, in homozygotes is a focus on the mechanisms related to APOE and trials specific to APOE4 homozygotes and with APOE-directed therapies. These are needed. On top of doing what we just did so far, that just being in the train with all the trials that are in the general population, that's fine. But we need to do more and to fight and accelerate the find of cures or treatments. Yes.
Yeah. I wonder if I might make some comments. Just a fantastic talk, fantastic points you're making. And you can tell from looking at the chat that everybody tremendously appreciates what you're doing. And I certainly do as well.
Thank you.
However, I want to say that one of the issues that has only sort of been skirted here is the question, well, okay, APOE, what does it do? Where did it come from? APOE has been around for, millions, hundreds of millions of years. The monkeys have it. All mammals have an APOE gene. The E3 appeared out of the E4. The E4 was our original gene 300,000 years ago. And somehow the APOE3 has been protected. And why is it? And we have a book I want to advertise. We have a book on APOE coming out. There's controversies about whether or not there's a dietary change that occurred 300,000 years, or whether there was a change in infectivity. Carr Smith, one of our co-authors, is on the call. Was there an infectious issue? Why the E4? Why did the E3 take over the E4? What is the mechanism? Dale Bredesen and Thramboseti's group up at the Buck Center said, well, there's actually 1,700 different genes that the APOE affects. But most people, and Molly very much is involved, saying there's something that's got to do with cholesterol. APOE is a cholesterol transporter. And what is it about cholesterol transport that could be relevant for Alzheimer's disease? Because all of the things you're looking at, amyloid, tau, they're all late stage changes from some underlying process. It's not that amyloid causes Alzheimer's. The amyloid is a result of the Alzheimer process. It is a result of having an APOE gene. What does that do? How does that lead to the deposits of amyloid so early, as it had been clearly shown even by John Morris? So these are extremely important questions. What does it do? Now, if you were to say that APOE is a cholesterol chaperone, there has been recent evidence that if you look at all the statin medications, which help some Alzheimer patients, it helps the E4/4 Alzheimer patients. There may be really good ways of preventing Alzheimer's disease if we really understood what APOE4 was doing. And if we could understand that, we might understand how to prevent Alzheimer's disease 100%. But I think if we're going to do that, we've got to start with the E4/4s, just as you've outlined. But we have to understand what we're doing and which drugs are going to be the ones that prevent it. I don't want my beta amyloid removed. I don't want to get it in the first place. And I don't mean that to be argumentative. I'm just saying I think it'll be much better if we could prevent this thing altogether. And I think based on your leadership, we can do it. So thank you so much for your presentation.
No, thank you very much, and for the comments. I completely agree. I think that to Dr. Axor, I do encourage you to see the map of the APOE prevalence across the world, and there are reasons to suggest that yes, diet. So for instance, in Europe, there is a gradient from Northern Europe to Southern Europe. So it's more frequent in Northern Europe than in Southern Europe. And people say that this has to do with diet and more caloric intakes, and that it was needed. No, it conferred an advantage in Northern Europe. But it's interesting that also in Africa, in some parts of Africa, it has to do with diet or infection. So I think this is fantastic from an evolutionary perspective how to do it. And the thing is that they say that evolution favored that because we have reproductive age is not in the age that we have Alzheimer's. This does not. It didn't have a pressure, and that what drove was these dietary changes and this kind of thing. I would say, if you allow me the joke, that now in Barcelona, at least, it's very difficult to have children if you don't have grandparents. So I think that now from an evolutionary perspective, the thing has been more complicated. But jokes aside, I think this is critical. And to your point, Dr. Ashford, the nature medicine with the diet is amazing. And it builds to your point. It builds that this Mediterranean diet had the largest effects in APOE4 homozygotes. And to your point, it's also the best population in which to have primary prevention. We call primary prevention when we try to prevent amyloid in the first place, as Dr. Ashford put it. And secondary prevention when you have amyloid, no symptoms, and you want to prevent the symptoms. These genetic populations are probably the only ones in which we can do primary prevention, because they are the ones that are likely to evolve. And so these things, if we want to get out, not even get amyloid, this is the population, it's APOE4 homozygotes, it's this Down syndrome, it's autosomal dominant, it's these populations in which we can investigate this mechanism. So yeah, I fully agree with all your comments.
Thank you so much.
Dr. Fortea, if you might ask a question about the penetrance of APOE4s, there's much higher in females, you mentioned. Can you expound upon that or explain it in layman's terms?
Yeah, so I think this has something to do. I think that there is solid evidence when most of some of the assumptions on the risk conferred by APOE4 is done in clinical genetic studies. So that means that you have very large numbers of individuals that had a clinical diagnosis, oftentimes out of medical charts, most of the times without the support of biomarkers, and this in my mind is critical. And then they perform the study. When you analyze that data, two things emerge. One thing is this ethnic differential risk across ethnicity, and the other is that this is true, that the effect, the risk conferred by the APOE to females, to women, seem to be higher than to men. The thing is that, as Dr. Axford is that this could be because the risk conferred by APOE is higher, or it could be because men have more mild cognitive impairment of dementia of all causes than women. And so if you do that ratio, it changes. So that's why I think, and I really think, that we really need to redo all the epidemiology in Alzheimer's based on biomarkers. So we really need to have a very good population-based estimates of the biological penetrance when you are amyloid positive or not. We really need to better estimates of MCI and with biomarker support, and of AD dementia. And that is because we really need these calculators. We need to do what the cardiovascular field has been doing, that they have these calculators, and based on your age, sex, genotype, and a bunch of factors, they can determine the risk that you have for different things. This is something that in theory we should be able to do, especially with the plasma biomarkers. With PET studies, the number, it was much more complicated to do because we didn't have the numbers. But with plasma biomarkers in Framingham, in all this population, I think that we should evolve into a better definition of the clinical symptoms. The inclusion of MCI, which is part of the symptomatic stages of disease, and as I said, biomarker support. And then we can redo all the epidemiology. And I think that we might have some surprises with respect to the ethnic variation, as some the work by Claudia Soemoto in Brazil is showing, and maybe also some surprises with respect to women. So I think this is critical questions to be addressed in the future. But yes, all the literature so far clearly indicates that the way we analyze it thus far, they confer a bigger risk for women.
Thank you. Do you do any studies take into account morbidity of APOE4s due to cardiovascular disease in determining the penetration of AD?
This is a very interesting point because, as you said, it reminds me, as I said, the controversies that we have in Down syndrome when we say how penetrant, how because if you die of other causes, or what we call medically competing causes of death, then you are infraestimating the risk, the lifetime risk of the disease. If you have someone that dies of a heart attack age 71 without developing Alzheimer's, you call him no Alzheimer's, and maybe had he lived longer, he would have more. This is what we want to address in this paper in Barcelona, basically this intersection between the cardiovascular, the Alzheimer's, and because this is hugely critical pathophysiology, it's not all about amyloid, that as Dr. Ashford was saying, amyloid I think is a very important part of this story, but certainly not all the part, and these independent cardiovascular factors and dependent cerebrovascular factor for AD, I think they're both, and their interaction are critical. So I think these are critical questions, and a lot of new research is needed.
After completing your study, what are the most important unanswered questions you're hoping to find in the future with your team?
So we really want to contribute so that APOE homozygotes receive the same kind of attention that AD received in terms of from NIH, FDA, pharma industry, targeted investigation. I think that AD did it 20 years ago. The DS, I didn't put the slide, maybe I should. The increase in the funding and the number of studies that we have in DSAD has increased dramatically. My hope is that if we can contribute to something, is that APOE4 homozygotes and APOE4 in general receive this extra extension. And I think that we should build the cohorts and get the trials. And I really like these trials that are with repurposing of drugs, and because are really fast. These fast trials, oftentimes drugs that have a very good safety profile. And imagine 2-3% of the population in Los Angeles, how many people you have? I mean, it's really a lot of people in which we could be doing and advancing this. So if we really take the opportunity, we see this as an opportunity. I honestly believe that APOE homozygotes could be one of the driving avenues to fight Alzheimer's for the general population.
If I can add one thing to that, you mentioned bumetanide, Bumax, as a possible treatment, and I'm on the Stanford IRB, so I had to review that protocol. But actually, it's not a Stanford study. It's a Yadong Wong at UC San Francisco. It's the one that did the analysis that found in the literature that was the top drug for associated with less Alzheimer's disease related to the APOE. And Yadong, of course, is an expert in APOE genotyping, works with Molly in San Francisco. But I think that's an extremely important study, and I really appreciate your mentioning it.
Yeah, I completely agree. Thank you for correcting me. And yes, I think you're referring to the Nature Neuroscience paper in 2021. He's one of the leading researchers in the APOE arena, and he's doing a terrific job. Yeah, and I completely agree. It's a very, very nice study that I'm really looking forward to the results.
Another question. I'm a APOE4 that participated in one of the earlier trials with antibodies. I've had to remove myself from the trial. What can I do to help prevent getting AD and diet and exercise?
So I think that the good thing about diet and exercise is that the side effects are always good. So if you have a healthy diet and exercise is going to be good for probably your brain. We have more and more evidence that it's going to be good for Alzheimer's. I think this Nature Medicine paper that was published earlier this year that I referred to is great. It conveys a lot of hope. It shows in my mind the distinctiveness In the metabolic signature, as Dr. Ashford was mentioning, the distinct metabolic signature, and the way that with diet we can impact that metabolic signature, and really this seems to have a very important effect. This, of course, is an observational study and needs to be confirmed later on in clinical trials, that we have to be very rigorous here in how we do things. But in itself, it shows that diet, that we all should be doing diet, and no, it's not always easy, but healthy diet and exercise is going to be for many things. And now what science is telling us, that maybe APOE4 homozygotes, for the reason Dr. Ashford mentioned, might be one of the subpopulations that benefit most from these things. And certainly, I think that stay tuned for all the clinical trials. I'm a big advocate in is the only way we have to advance, basically, is through clinical trials. So I think that you'll get the opportunities to participate in research, to benefit from treatments that otherwise are years away, and you will not possibly not otherwise benefit from. And of course, you're contributing to the advancement, and all the advances in medicine and the drugs we have is because some people participated in trials. So it's at the same time generous and selfish. Selfish because you receive treatments that otherwise you're not accessing to, and generous because you're contributing to the effort. And of course, I'm very cognizant that this takes an effort. There are some risks in some trials, but I do believe that this is honestly is the only way forward. If we don't have trials, we will not have drugs.
Absolutely. You mentioned that there's a need for distinct APOE4 clinical trials. Do you anticipate or do you think APOE4 carriers might respond differently to trials in different compounds? Can you explore that a little bit?
I think so. I'm convinced. I think that's why we do believe that of the distinctiveness of the disease. We're not playing here a semantic game. Here is what we are seeing is, as I said, in the current trials that are approved, there's no question whatsoever that their side effects are different. There is a gene dose effect on the risk of ARIA. So the more APOE you have, the more risk that you have. There are questions about whether the response is the same or not in APOE homozygotes. They've cleared less amyloid. It could be because of the ARIA they receive less drug. I think that we are learning about that, but not only risk, it might be that the efficacy is lesser. We need to explore that a bit further. So very clear in the current drugs. Valiltramiprosate, the Alzheimer trial, the APOE4 trial, there what they did is analyze a subset and saying that in that drug, it was possibly the opposite effect, is that it was a safe drug and with potentially much larger effects in APOE4 homozygotes. So that a drug that might not work in the general population might work in this subpopulation. So that's another reason why we should be exploring these things. And the other trial that we just discussed, that's Dr. Juan, that identified a compound that computationally, theoretically, could reverse much of the transcriptomic changes seen in APOE homozygotes and move on to animal models and to registry studies to show that it has. And then, on top of all this, there are things that need to be only in APOE homozygotes. So if we're silencing APOE4, by definition, you should have an APOE4. So this is a trial that can only be done in APOE homozygotes. So that's why I say, the way I see it is that we still should be in the train of all the trials in the general population, but there are things that need to be done in APOE4 because it cannot be done with, you cannot have an ASO against APOE4 if you are not an APOE4 carrier by definition. But on top of that, we must ensure and convince the FDA and the pharma that they always consider the powering their studies so that we can assess the safety and efficacy in this subpopulation so that we don't end up guessing whether or not, because some people have said, "What? Don't say this because maybe the people we prove that donanemab is not useful in APOE homozygotes." I don't think it's the case. Let me say that I don't think the case, but imagine it was the case. We follow the data. Is that fear should not be our driver. It should be science and data. So if the donanemab were unlucky enough and donanemab wasn't effective, it's better not to prescribe it, especially because you have side effects. So let's follow the data, basically. So that's what I'm arguing is like, let's follow the data and we evolve as the science is developing and the evidence.
I want to continue this just a little further, because I mean, Dr. Fortea is making such important points here. And I want to, people may not want to talk about Down syndrome, but Down syndrome, as he pointed out, is an amyloid disorder. You have 50% too much of the amyloid precursor protein. The amyloid genes that are related to Alzheimer's, those are amyloid problems. So focus on the amyloid for those cases. But what does APOE do? How does the APOE relate to this? And I think that that's incredibly important to understand. This is where I think the whole concept of neuroplasticity comes in. We talk about Brock stage. Well, Brock retracted some of his things about where Alzheimer's affected first. It's in the brainstem. Norepinephrine, serotonin, acetylcholine mechanisms, neurons coming out of the brainstem are affected. Carlton Gajicek, Nobel Prize winner, said, oh, it's long neurons. No, it's not long neurons. The long motor neurons are not affected at all by Alzheimer's. It's the neurons that have high degrees of neuroplasticity and high synapse turnover, which means high levels of cholesterol turnover. And so I think that's the level we have to understand APOE and then help to prevent Alzheimer's disease. I think that what he's saying is just, I can't believe that I've had to wait 30 years to hear this. This is what we need to hear. We need to act on.
Yeah, no, I completely agree with you. And this plasticity, this is something that is emerging, no, in different groups. The retromer complex and the entorhinal as one of the things that is having a lot of turnover, and the membranes and the cholesterol, to your point. And also, very importantly, in Alzheimer's, and it hasn't received, in my mind, enough attention, the cholinergic system and the denervation in the basal forebrain, that is the main source of acetylcholine to our brain. And this is extremely important for plasticity, to Dr. Ashford's point, and this is clearly early on in all these genetic forms of Alzheimer's. And to your point, this modifier, so APOE does modify the effect of the presentation of the disease in Down syndrome. So it accelerates. And here we don't have the power to dissect the homozygotes and heterozygotes, and although I'm always kind of advocating you need to separate homozygotes and heterozygotes. Heterozygotes are usually in the middle, so it would make the same sense to put them with the APOE3s or the APOE4s. They're in the middle. We are just collapsing them with APOE4 because oftentimes we don't have the numbers. So I have to admit that we did that in Down syndrome. We didn't have the numbers for APOE4 homozygotes. But with APOE4 carriers, they have they present the disease 2 years earlier. And what's interesting, and this is unpublished data, we published that once. I hope he doesn't get mad at me for saying with us unpublished data. But it's very interesting because we're collaborating in a large Barcelona cohort and the ABCDS in the US. And the APOE2 has a larger effect in Down syndrome than the APOE4. And that, in my mind, it's because probably, as I said, there is more to it in APOE than amyloid. As we're discussing the cholesterol, many, the diet, the metabolome, and so on. But amyloid is part of the story for sure. I mean, APOE4, you have a much higher chance of having amyloid. But because people with Down syndrome, as Dr. Ashford said, have so much amyloid. They don't need whatsoever the APOE4 to get the amyloid. They have more amyloid than they need, so to speak. So the conferred risk of APOE in Down syndrome is through independent mechanisms of amyloid, which I think is really cool because we can assess these mechanisms, because amyloid, the effect of APOE4 in Down syndrome has nothing to do with amyloid. They have more amyloid so that we can assess these mechanisms. But the cool thing is that this effect, probably because we are taking the amyloid effect of APOE4, is smaller than the protective effect of APOE2. The protective APOE2 in this population is even larger. And I think this is the kind of mechanism, this interaction between these genetic forms that provide you these new angles that could be extremely informative in developing new avenues for treatment and therapy.
Jump in?
Dr. Ashford, let Nancy go, and we are running a little bit short on time. It's been an hour and a half, and the time we put a limit on this. So
I'm going to give way to stop Alzheimer's.
Sure.
Go on, I'll tell you later.
Okay. So, Dr. Fortea, I actually mentioned earlier that I am one of those 2% of people with APOE4 and have a very rich family history of both cardiac, early death from cardiac disease and stroke, and late onset Alzheimer's. And, was also one of those people who found out that I had elevated amyloid. So that train has left the station. And so your comments about the FDA, I think, are really important, because There is a lot of controversy over whether the FDA should have gone beyond black box warnings for APOE4 homozygotes, whether, as Europe did, they should have approved the drugs for APOE heterozygotes, but not homozygotes. There are a lot of respected centers here who let people like me take the drugs if they have MCI. I have friends who are doing that. I'm in the AHEAD trial myself. And so I really want to endorse the idea that it's belt and suspenders and every other strategy also. I've never heard a researcher like yourself not emphasize that this is a complex disease and we should be starting as early as possible, including early life education, to prevent and reduce the risk. And that also we need to include people who have these risks at the table, talking with the FDA about how better to design trials, how better to ensure safety, how to reduce and manage ARIA. And I really think that what you're saying is a message of hope, which is what I believe. So thank you.
No, thank you for that. And I honestly believe that I recognize that, of course, the paper, and I receive a lot of emails of people worried. So this is, I recognize that, of course, this reconciliation comes with this concern of many people. As I said, we've been there in Down syndrome. It's a smaller group, but it's more vulnerable even. And so raising this concern and raising this awareness. I remember 10 years ago, in community and in Association for Down syndrome, and you talk about Alzheimer's, and for them it was like, oh no, that's the last thing we want after a life of fighting for many things, so many comorbidities, so many difficulties, and then you came with Alzheimer's. So I'm really sensitive to this issue. But as I said, the only way forward is to follow the data, the science, not hide away from it and confront it. And I think that, and now we're in a much better situation because of the moment that we're living in the field with all these advancements than when we were saying the same thing for Down syndrome, because at that moment it's like you are not aware of, but this is a huge thing that is coming, and we had less to offer. Now, when I give the talks for Down syndrome and APOE4, I'm full of hope, and I'm full of hope, and I think that we'll be seeing very significant changes in the near future.
Well, thank you so much. And in closing, I just want to say there's a number of questions that have gone unanswered, and we will try to answer all those questions and share some of them with Dr. Fortea and put them on our website. It's also our intention to keep this video housed on our website and APOE4 info as well. So I really do appreciate all the panelists and participating today. It was extremely informative and insightful. I think we are calling to action, not just the medical community that you represent, but the patient community, and really bringing our voice to the table at FDA and NIH. Our goal is to do a number of engagements with the FDA and NIH in the coming year. We want to do a patient-focused drug development meeting with the FDA to educate them about our population and enforce the concerns we have about the participation of our patients in clinical trials, and making sure there are more dedicated clinical trials for these patients. We really look forward to working with you and Dr. Ashford and trying to help that happen, make that a reality. And would love for you to participate with us when we do go to the FDA and NIH. So with that, I want to close and say a heartfelt thank you to Dr. Ashford and Dr. Fortea for presenting today. And we very much appreciate all the effort you've put forward.
We need a book we're going to have to write a big, long chapter on this to answer all these questions. So, Bill, you're going to have to help us with that.
Yes, absolutely. Yeah, there's a lot
I've got a lot of answers to some of these questions I'd love to put out.
Absolutely. We will make sure they're housed on our website, and we will share. Everyone has registered with an email. We'll be back in touch with you, and we are going to be calling you to action, to write your members of Congress, to write the FDA, and to write NIH. Right? We have to have a much louder voice than we've had to date in order to move this forward. And we do our call to arms is starting here, and we're going to hopefully expand upon it in the coming months. Thanks so much for your time, and appreciate everyone participating.
Thank you very much.
Thank you.